Hi, hello everyone. This is Kees Brinkman here. I'm calling from Amsterdam, so here it's afternoon. Welcome to everyone to session number 2. We are going to discuss the patient-reported outcome, which is becoming much more important for people with HIV. A lot of clinics are working with this. I'm very happy to introduce Richard Harding. Richard is a Dunhill professor at King's College in London, and he is working already for some while in the field of HIV, and he has a lot of experience with the PROMs, and he is going to discuss, does it really matter, and how can we best determine them? I hand over the microphone to Richard.
Thank you. So I'll talk today on patient-reported outcome measures, which ones really matter, and how do we determine them? How do we decide on which outcomes and which measures? So the first thing I'd like to briefly focus on is what we mean by an outcome. So the definition in Donabedian's definition of quality is that an outcome is the change in a patient's current and future health status that can be attributed to preceding healthcare. So an outcome is a change that occurs in a patient's well-being that we can attribute to the healthcare that they have received. So we may focus in research on our inputs and our structures, the processes of care, the outputs of care, but it's essential if we really want to understand if we're making a difference that we focus on outcomes. I also want to orient us briefly to the idea of person-oriented care. And my colleague at the Institute of Human Virology, Carla Alexander, coined the phrase from the life of the virus to the life of the host. And where we try to focus in person-centered care is on a patient's physical problems, their emotional problems, their social problems, and their spiritual problems. And if we're able to do this using a valid, routinely used patient-reported outcome measure, then we have the opportunity to make sure that care is good quality, that it's accessible to patients, and that most importantly, it reflects what matters to them. So we do know that patient-reported outcomes are clinically important. What a patient can identify really matters in clinical management of people living with HIV. If we take the example of pain, we know that pain is a highly prevalent concern for people living with HIV. It has to be self-reported, and it's associated with a number of outcomes, including poorer quality of life, viral rebound, sexual risk-taking, poor adherence to treatment, treatment switching, and suicidal ideation. We've identified that in a number of cross-sectional studies. The work by Jesse Merlin in the US has also identified that among the HIV outpatient cohort, 25% had chronic pain, and that's associated with no shows for at least one primary care visit. And chronic pain is associated with both no shows and virologic failure. So these are outcomes that matter. So thinking more about the concept of person-centeredness for people living with HIV, we know from research that health-related quality of life for people living with HIV on treatment is poorer than the general population. That's from a UK study. And we know also that not only are people living with a high symptom burden, which may be physical, psychological, social, and spiritual, but there are emerging physical complications as people age with HIV. The contribution of physical and mental health to health-related quality of life has been identified as our current critical challenge in HIV medicine, and I think that's an ongoing challenge. And in terms of what people say is their experience of HIV outpatient care, outpatient attendees perceive that care doesn't address the issues of physical, mental, and social well-being that matter to them. So in terms of patient-reported outcome measures, what's the mechanism? What are we trying to achieve? Well, we know from the early work of Amy Justice in the USA that HIV practitioners often miss patients' needs and symptoms, especially non-physical ones. And she showed in research that an HIV clinician will detect around 1/3 of patients' concerns during a clinical assessment. We also know from the broader PROM literature that if you routinely use PROMs, it can help identify problems and concerns, helps improve outcomes for patients, and that's through team sharing and planning. So using routine data that's been collected to inform an assessment and to inform a care plan and to evaluate it. We're also aware that there was no brief person-centred patient-reported outcome measure that reflects the range of outcomes that are relevant for people living with HIV, that would enable us to drive and evaluate care. So what we're really talking about here is outcome measures that measure things that are actionable and specific, therefore useful to the clinical encounter. And we've also had to think about what's the construct that we aim to measure here. So there are some challenges around whether we want to measure quality of life, which may be more conceptual, or a construct such as symptoms and concerns, which may be more actionable in the clinical encounter. And also, of course, what we aim to do is support the fourth 90, which has been promoted by Jeff Lazarus and his team in the debates around quality of life. And this paper that we published earlier this year around quality of life and patient-reported outcome measures identified that there are some challenges that remain in the collection, interpretation, and use of PROM data for people living with HIV. And we also know that patient involvement in development of PROMs is absolutely key to make sure that they're usable, acceptable, and reflect what matters to our population of interest. And of course, here in the UK, in our standards of care for people living with HIV, we now have a standard of person-centred care. That's what we should be expecting to deliver and receive. And these standards were co-authored by community and clinical colleagues. So I'd like to talk briefly now about the positive outcome study, which is a novel patient-reported outcome measure for people living with HIV, which we've been developing to improve person-centeredness of care, to inform holistic assessment and quality improvement, and to develop a measure that have both a clinical and a research function. The construct that we're measuring with this is clearly symptoms and concerns because we want it to be used in routine practice. And there are a number of papers we've published now on the development and initial validation stages of the positive outcomes, patient-reported outcome measure. And I'd also like to acknowledge all of the colleagues on this slide who have been part of the positive outcomes program of research. Really importantly, we have followed best practice in the development and testing of health outcome measurements. So in addition to the existing guidance on outcome measurement development, we've tried to follow very closely the Rothrock model, which is really enabling us to think carefully about the conceptual development, generation and validation of the measure so that it has optimum chance of being usable in routine practice. So first of all, we wanted to determine the priorities of adults living with HIV in terms of measuring their outcomes of care, to develop the patient-reported outcome measure, and also to determine how it should be best implemented to improve patient-centeredness from the perspective of people living with HIV, their clinicians and commissioners. So this is an observational study in line with the COSMIN taxonomy and guidance, as well as the Rothrock guidance. And again, I would refer you back to our papers that have been published in the last 18 months. So in terms of our methods, we use the COSMIN taxonomy and the Rothrock guidance. We conducted 57 stakeholder interviews, including people living with HIV, healthcare professionals and commissioners. And we determined their primary outcomes, what should we be measuring, the optimal recall period, the length of the measure, what the response levels should be, and the domains of interest. And then we had an expert meeting for item generation, which included people living with HIV, clinicians, academics. And then we've been working on item improvement through 6 cognitive interviews, and we have concluded with 22 items and 1 global item for the measure. So in terms of what we've found in this work, well, first of all, patients and participants in the research describe very diverse but interrelated problems and concerns. And there are 6 domains of primarily that they wanted to be included in the PROM. Those were physical concerns, cognitive concerns, psychological concerns, issues around welfare, social needs, and information needs. Also, participants really wanted to have a global item which would assess well-being and free text opportunities to discuss particular issues further. And there's an example on the right, a quote from one of our participants just talking about the interaction between issues like fatigue, education, cognitive challenges, which can really affect the whole sense of self and social participation. So what might be the benefits of using a PROM? Well, for people living with HIV, there was a sense that it would enable patient-centeredness and empower people living with HIV within their healthcare, to help them raise their concerns and to feel heard, to feel valued, and better enable them to share their sensitive information, to build resilience and self-confidence, to encourage referrals, importantly, to reduce assumptions. So making sure you understand really what matters to the patient rather than what you presume matters, helping to get to know patients, and most crucially, moving beyond adherence and viral load as our end concern alone. For services, HIV clinicians felt that it would better enable them to tailor their services and their care to specific populations, to understand how HIV is changing for people living with HIV, to improve efficiency, and to build confidence in clinicians in handling less medical issues, and of course to justify current spending. I think this is an interesting pair of quotes here. The person living with HIV, when we asked them, what would you like to be discussing in your clinical encounters, said, I think in general terms, I would like to hear them say, how is your physical health? How is your weight? How is your mobility? Is there anything going on there? Whereas when we asked the commissioner, which in the UK means those within the health system who are paying for HIV services, who purchase them, said, I'd expect adherence to be discussed in their clinic appointment. I'd expect them to be updated on their latest blood results. I'd expect partner notification. So you can see a real contradiction here between what people living with HIV think should be discussed and what those within the health system paying for health services think should be discussed. So person-centered care now is our goal, and we really believe that the PROM is our way to achieve it, and community have absolutely been at the heart of what we're doing. And here is the measure that we've developed. I'm just sharing the first few questions here, which has open text opportunity first of all, then the overall global item on health and well-being in the last 4 weeks, then questions about information, and then moving on to physical health and well-being. So the first few questions in that are around pain, stomach or bowel problems, memory or concentration, and sleep. The validation of this measure is now complete. I'm delighted to say that 2,251 people living with HIV completed this measure at least once. And that was a large cohort of people living in Brighton and Sussex, in Belgium, in Spain, in Croatia, and in Portugal. And that data will be presented at the Beaver conference here in the UK next month in November. So in conclusion, we know from the evidence from across health conditions that PROMs provide a well-established mechanism to make care more person-centered. If you routinely enable people to discuss what matters to them, you can quickly focus down on their main symptoms and concerns. Selection of a measure is absolutely crucial. You need adequate psychometric properties. That work I showed you around Rothrock and the Cosmin guidance is absolutely crucial. You can't just make up a questionnaire. And particularly face and content validity is important for people living with HIV. Rather than a generic quality of life measure, we need to make sure that we are measuring what matters. Then using the data in a data use cycle is crucial. Completing a PROM on its own will have little value compared to using that data to guide to discussion. And lastly, implementation strategies are absolutely key in PROM successes, and the implementation science of how you empower people to use this and how you can make sure it's routinely adopted and the data is used is absolutely key if we're to really achieve the potential that PROMs offer us. Thank you.
Thank you, Dr. Richard Harding. It was a very inspiring talk. You've done a lot of work already about the importance of PROMs. I want to focus on everyone in the audience. There is a chat function, so if you have questions in between, because we are going to have a live discussion after the two presentations, please use your chat function to propose some questions so we can discuss them. We will continue though. I want to introduce now Diana Barger. Diana Barger works in France, in Bordeaux. And she also has lots of experience with patient-related outcomes in the field of HIV, and she will now share her experiences with in the next talk.
Good afternoon, everyone. I'd like to thank the organizers for inviting me to speak today on the topic of patient-reported outcomes in HIV. Here are my disclosures. So I'd like to start by reminding us of a common scene that illustrates, I think, quite well why patient-reported outcomes are important. Here we have an HIV clinician who's reviewed their patient's most recent blood work and reports, "Great news, you've achieved viral suppression. You're responding really well to antiretroviral therapy." But meanwhile, we see the patient who's thinking, "This diagnosis has affected my whole life. I'm having trouble sleeping. I feel tired. I'm getting headaches." So we understand that these concerns are perceived as relatively minor by the physician in the scope of her larger healthcare needs. However, they remain important to the patient and often his or her quality of life. So unlike standard clinical outcomes, like viral suppression, like mortality, patient-reported outcomes can provide us with unique insights into how care or given therapy can affect a patient. They lead us to be more focused on the real benefits that patients seek to help us overcome asymmetries in doctor-patient communication. So our ability to make use of these insights can affect not only individual patient care, but also the quality of care that we deliver to patient populations. So patient-reported outcomes, or PROs, are defined as any report of the status of a patient's health condition that comes directly from the patient, without interpretation of the patient's response by the clinician or anyone else. A PROM, or a patient-reported outcome measure, simply refers to the tools that we use to capture the PRO's information directly from patients. PROMs can either be generic or disease-specific. Generic instruments enable us to compare across patient populations. However, some of these are not sensitive to specific domains that might be especially important to a given patient population. So you may already be familiar with the use of patient-reported outcomes in clinical trials, as these measures were initially developed as secondary endpoints. However, today I will draw your attention to a different application of patient-reported outcomes, their use in clinical practice. So here, this taxonomy that was provided and developed by Greenhall and colleagues shows us that patient-reported data can be used at the individual and the group level, and can also be used in the clinician-patient interface. So here we see at the individual level, patient data can be used to screen, to monitor, and to promote patient-centered care. It can also be used to facilitate communication with an interdisciplinary team. Aggregated PROMs data can be used for shared decision-making and population monitoring and assessing quality of care. It can also inform service design and redesign. So I think that the environment has become increasingly conducive. However, it's not without challenges. In the last 20 to 30 years, we've seen HIV care evolve immensely with the normalization of life expectancy, and now we're in a chronic care model. We've also seen new tools to measure patient-reported out data and new methods as well, like item response theory. The infrastructure has also changed and has evolved in our favor. With computing, we can now use tablets and web applications, electronic health records, to help us and capture patient-reported data and also process it almost in real time. The regulatory environment is also conducive to the application of patient-reported outcomes in clinical care. As we see demands from authorities, institutions, clinicians to measure and demonstrate improved outcomes at the individual service and health systems level. So how are PROs measured, and what makes a good PROM? So the easy answer is that PROs are measured using questionnaires or instruments, and we expect these questionnaires to have sound measurement properties. We want them to be valid. We want them to measure what they're purported to measure. We want them to be reliable. In other words, we want to do this in a consistent fashion. We want them to be responsive. We want to see evidence that they are able to capture clinically meaningful change. And finally, interpretable. Now, this point, along with the point of logistic feasibility, is especially important if we want to achieve the integration of patient-reported data at all levels of healthcare. And we have to ensure that the tools that we're selecting can be easily administered and do not overburden either the patients or the clinicians. And we have to ensure that the scores that we're generating can be interpreted by different stakeholders, be they clinicians, patients, or healthcare administrators. So, are there measures available in the field of HIV? Now, our colleagues Kim Engler in Canada did an amazing inventory of 117 HIV-specific PROs instruments that covered 12 different concepts. One of the most prominent concepts was health-related quality of life, where they identified 23 HIV-specific instruments. Art and art adherence was also prominently represented among the HIV-specific PROMs, with 19 different instruments identified. When we talk about health-related quality of life, a common patient-reported outcome, we see in 2017 that Vanessa Cooper and colleagues published a systematic review of reviews in which they tried to identify and especially really to narrow down which tools, which of these HIV-specific instruments designed to measure health-related quality of life were actually able to be administered in less than 10 minutes, meaning they were feasible. They had been developed with input from people living with HIV, and they were sufficiently comprehensive. And then they further specified that for generic scales, there had to be available normative data. So these colleagues were able to identify 9 generic scales and 7 HIV-specific scales, so 7 among the 23 that were also identified by Engler and colleagues. So we concluded that there was really an absence of a gold standard here, that the choice of the scale is often a function of a specific research question and the end use. But that Cooper and colleagues pointed to 2 newer scales, at least for the measure of health-related quality of life, which were promising, but often these scales needed further validation, especially if they were going to be administered in new populations or in new target languages. So this is also more recent work by Cal and colleagues in the HIV series on HIV outcomes, where colleagues pointed to a number of different generic or HIV-specific tools that could be used to measure health-related quality of life, patient empowerment, or other PROMs of interest. I'd like to draw our attention quickly to a prose that was developed rather recently by our colleagues in France. The ProQual HIV is one of the newer instruments designed to measure multidimensional health-related quality of life. Here we see that energy, sleep, coping, these were the newer themes that emerged from extensive qualitative research conducted across 9 different countries in the mid-2000s. And we should be considering what themes are relevant for care today. And this brings me to my next slide. So we see that there are instruments that are available, but are they all relevant? And I think we should be asking ourselves the following questions. Why were they developed? Were they developed to assess immediate response to antiretroviral therapy in the late 90s? Were they developed using in patient populations that no longer reflect those currently in care today? Another quite provocative question is, do we really need HIV-specific instruments? And this is a question that emerged from the validation of the ProQual HIV breath in a population where the 90-90-90 targets had been achieved. We noted that 2 of the domains showed poorer or less than optimal internal consistency, and this might have been due to some of the HIV-specific items that might no longer be relevant in those who are in Europe and potentially very well cared for. So the last point is, when we're evaluating these new instruments, we're interested in their ability to detect clinically meaningful change. Now in HIV, historically, we've seen that as achieving viral suppression, or seeing CD4 cell counts increase, or different HIV stages based on the CDC clinical categories. Now, this is going to be increasingly difficult if we're talking about chronic HIV care, where we expect fewer and fewer people to actually progress to advanced disease. So I wonder, how do we validate new instruments in populations where fewer and fewer people are expected to experience advanced disease? Now, going back to the integration of HIV, of PROMs into HIV care. So in the work that I'm involved in Bordeaux, integrating electronic and paper patient-reported outcome measures into routine HIV care, and using the ANRS CO3 ACI-10 cohorts data capture and visualization system to do that work, we published this protocol in 2018, where we described the steps where we selected what instruments we were going to use, and how we developed and tested the instrument to see if it was going to be feasible. We concluded this paper by reflecting on how we hope to move forward with this work, namely to integrate these measures into clinical care. And we developed this conceptual framework, where we described that the provision of this information to clinicians might result in changes to doctor-patient and communication. This is what I presented in the first slide. Now, these changes to doctor-patient communication might influence the way in which clinicians monitor treatment. It also might result in the early detection of unrecognized problems. We see that the early detection of unrecognized problems might lead to changes in the clinical management of patients. For example, the referral to a specialist, further testing, more individualized advice on management, which ultimately could lead to improved health outcomes. Monitoring treatment response could also lead to changes in patient behavior, and this is something that I think we're all struggling with when we consider what long-term HIV care looks like. So of course, we think of adherence to ART, but not only. We're thinking about tobacco suppression, tobacco cessation, physical activity, maybe weight management, or different interventions that are preventative that could become part of standard HIV care. Now, the proximal mechanisms here are changes to patient health behavior and changes to clinician management, and we expect that those have to occur in order for patient satisfaction or improved outcomes to be achieved. But as you see from this slide, the mechanisms are extremely complex, and we have to consider this as we further integrate this data into HIV care. Now, this work is really ongoing, and I wanted to highlight the work being done in the United States by pioneers at the University of Washington. Now, they've began, as we have in Bordeaux, integrating the provision of patient-reported data that was initially collected for research into routine care. So they have patients complete a PROS data battery while they're waiting for their HIV consultation, and they do this at every single consultation. And at the time that this work was beginning, that was as frequently as every 4 to 6 months. The content of the PROS battery is focused on a depression screening, an ART adherence screening, substance abuse, and HIV risk. And in this later work, they compared medical records documentation and intervention before and after PROMs were shared with clinicians, and when and if a clinically relevant depression or risk was reported. And they found that providers increased their documentation of depression, of at-risk alcohol use, of substance use, of inadequate adherence once they were provided with this additional PROS data. However, not all of these areas were followed up. Clinicians tended to follow up depression and inadequate adherence, but at-risk alcohol use or substance use were neglected. So this needs to be really considered as we think about the goals of these tools. So to conclude, PROs data have a really important and potential role to play in HIV care. And although response to treatment may not be our primary concern, early detection of unrecognized problems and behavior change certainly are. There's still no consensus about the best PROM measure, and at least for health-related quality of life, we definitely have challenges when it comes to responsiveness and interpretability, and whether or not we should favor unidimensional or multidimensional PROMs. So the last point is, when do we administer these instruments in the context of chronic disease care? And how do we ensure that the infrastructure is conducive and that space is made for these assessments? And how do we facilitate interpretation by clinicians? Finally, I think that this conference and other efforts are extremely important for creating buy-in from all concerned parties, because we need to show and consistently demonstrate that these tools have value, and that requires additional evaluation. I look forward to getting your questions, and thank you very much for your attention.
The chat function. So if you have some pressing questions or experiences you want to share, please put them in the chat so we can discuss them after this session. To continue with the session itself, it's my pleasure to introduce Giulio Corbelli. He is from the European AIDS Treatment Group situated in Rome, Italy. He's HIV positive already for several years, and he's going to share with us the ethnic, gender, and cultural considerations in patient-related outcomes and their significance. So please, Giulio, take us with you.
Thank you very much for inviting me to this workshop to present about ethnic, gender, and cultural considerations in PROMs and their significance. My name is Giulio Maria Corbelli. I'm a member of the European AIDS Treatment Group, and these are my disclosure. Let me take just 1 minute to introduce myself. I've been diagnosed with HIV in 1997, and since then I've been working as a community journalist, especially in gay media, focusing on sexual health. In 2009, I joined the European AIDS Treatment Group, and that was a great opportunity for me to expand my knowledge about medicine development and clinical research. I also chaired the European Community Advisory Board for some years, which is the body involved in medicine development and clinical research within EATG, mostly involved. So I also represented EATG at EMA since 2016. I'm a member of some research groups and also of the ethics committee at the National Institute of Infectious Diseases in Rome. Now, within these roles, I had the opportunity to know something about PROs, especially as ICAP chair in 2018. We launched a program trying to increase the knowledge among ICAP members about PROs, and also establishing a conversation among ourselves, trying to identify those items, those points which are priorities for us to advocate for in PRO. We had some training, also meeting with companies, discussing with them their activities about patient-reported outcomes. And now, last March, EATG launched a specific project on PRO called PROMs, which will develop a framework, a model framework, a working framework for the use of HIV-specific PROMs in HIV research and development, and for the inclusion of people living with HIV in the further development of PROMs. Now, why I'm telling you all of this? This is to say that I am not an expert in technicalities about PROs. So I am sorry, but I will not be able to tell you anything related to the how to ask questions or how to build up a questionnaire, of course. But I'm a person living with HIV. So I know how important my well-being is beyond the viral control. I know how important in the health sector all those areas investigated by PROs, how important they are in our lives. Also, I know the importance of these items in medicine development, so I know how it is important to advocate for their inclusion in medicine development, and to see how better to include them. But last but not least, I am a man, I am white, I live in the EU. Yes, I am gay, but I'm just a gay man. I'm not a trans person. I'm not many other things. Why I'm saying this? Because I don't think that I am the one who should say something about the ethnic consideration, for example, or the gender consideration. I cannot speak on behalf of my trans friends. I cannot speak on behalf of my female friends. I cannot speak on behalf of my black friends and so on, and any other ethnic minority. This is crucial in my view. If we want to have an open conversation about that, we need to ask these questions to the people who are involved in this process, in these problems also sometimes. So the right people should be involved. I can just present my personal consideration, which may be not relevant at all for all of you, which could also be discussed by other colleagues of mine because they may have a different point of view. But we will see this in a minute. Now, the first question that we asked within ECAB while assessing this issue related to PROMs is, do these tools, those that are validated and most used also in HIV research, really answer the questions which are relevant to us? I don't think so, and most of my colleagues do not think so. Many questions that I read in these validated tools are kind of asking something which is not does not capture the reality of my life. My social life is much more complex than asking whether it is perfect, it is slightly changed from the past, it is moderately changed from the past, or severely, extremely changed, like done in the COP-WP NCA questionnaire. Also, mobility. I have no problems in walking around. I have some problems. I am confined to bed. This is something which might be relevant in the past when people living with HIV were mostly affected by AIDS. But now the reality is much different. So another important issue is these tools, are they developed together with representatives from our communities? If we look at this diagram that shows how the PRO-QOL HIV questionnaire was developed, actually the involvement of people living with HIV was just because someone asked them to fill in a draft of the questionnaire and tell them what they think. I am not sure that this is exactly an example of real involvement. Okay. Also, most used PROs in HIV are quite outdated. They were developed more than 20 years ago. How can they represent the reality of nowadays, realities of people living with HIV? We need more up-to-date tools. We need also more flexible tools, because if we develop a tool now in 2020, that could be outdated in 2 years, because long-acting treatment are widely available, for example. So we need to be flexible, to find a way to make these tools flexible for the application. The validation process is too long and too cumbersome to allow these tools to be adapted to the reality. Some few slides to answer your real question. I'm sorry if I'm not able to address the question I was asked to address. Now, some ethnic consideration in PROMs. You know much better than me the complexity also of definition of race, ethnicity, and so on. But I just want to tell you something about my personal experience as an advocate related to this issue. Within EATG, we had an open conversation trying to understand whether the use of the term race was appropriate in scientific literature and scientific research. Our argument was that there is no scientific definition or background for race. We are all equals. There is no genetic difference, for example, to identify races. There is no scientific definition for race. So maybe, we argue, it is good to avoid the use of this term. Maybe we can just use the term ethnicity, which is more related to the community I belong to, or something like that. When we included in this conversation some colleagues living in the US, and especially some black colleagues living in the US, they were kind of not that convinced that this is the right thing to do. Because if we avoid the term race in scientific literature, we risk to erase their identity, a part of their identity, an important part of their identity. So this is not something that we want to do, of course. We want to capture the complexity of the identity of everybody and all the people. So we should try and identify a way to assess that identity, of course without being discriminatory, but trying to capture the reality. And this is quite complex because you know much better than me also that race is an aspect of this identity, but is very strictly connected with many other aspects that have to do with the financial, social, educational status of that person. So and the same applies to me, for example. So this complex reality should not be identified with just one aspect, for example race, because it's much more complex. Okay. Gender consideration, another example of a complexity. We started by asking, what is your gender, male or female? Okay, which is very simple. But then we realized that the reality is much more complex. We could identify which gender you identify with, and that's a good way to approach. But most LGBT organizations now agree that the most appropriate way to ask for gender identity to a responder to a questionnaire is by using two questions, as you know. Which gender or sex were you assigned at birth, and which gender do you identify with now? Which one describes you better? Because sex assigned at birth may be different from the one I identify with, of course, as you know. But there are also many other complexities. Now, this is a very simple example of how we need to be very careful when writing a question in a questionnaire, because we want to capture all the complexity of the responders to that questionnaire. But do we need to capture really everything in our surveys? Now, my personal answer to this question is yes, for many reasons. Because if we want to simplify, which is something we do usually in any kind of research, we may miss something important. But, and this is an aspect that you know better than me, but some other aspects are related to how people can feel that they can contribute to your research. So if you ask me to fill in a questionnaire and I read questions that have nothing to do with my experience, with my life, I will just think that you are losing my time, wasting my time, sorry. So it is pretty useless. We should try to involve people, and involving people means involve people since the very beginning. Participatory research is something which is generally it began to be applied in some aspects of clinical research. It should be applied more, but should also be applied in social research. It is very important to develop these tools together with the representatives of the community, taking into consideration that people are very complex and not all people with HIV are similar. Some years ago at the Gay Pride in Rome, I wore this t-shirt, people living with HIV are, and asked people to write an answer on that t-shirt. I collected more than 50 answers, the one different from the other. So the complexity is really high, and we need to take this into consideration if we want to develop tools that are appropriate for our community. Thank you very much for your attention.
Well, thank you very much, Giulio. This is a very well, reflective talk, I would say. We just heard very enthusiastic talks about how we should implement PROMs in our clinical practice. And you gave it a very personal view that probably not for everyone, everyone is waiting for these initiatives. So we will discuss that in a moment. Unfortunately, Giulio is not joining the question and answer session, but Diana and Richard are. I first have a question for Diana because it's about her talk. Kim Engler asks what the current status is of the Qualif project at the moment. I can't hear you, so. For me, Diana, this is important, impossible. I cannot hear Diana.
I'm unmuted now.
Yeah, I can hear.
Okay, it's okay?
Yes.
So thank you very much for this question. So the CaliV project was launched officially in the first hospital in July of 2018, and we're now currently recruiting participants in 8 different settings. So there's been a progressive opening and adaptation that's happened across both hospitals that are located in an urban setting in Bordeaux, but also smaller peripheral hospitals located in Bayonne, which is in the south of France, and Périgueux, and also in Poitiers, with all very different patient populations and staff in those different settings. And we've learned a lot in terms of people's ability to complete online assessments, and seeing a different breakdown in terms of who's able to complete an online assessment versus a paper assessment. And so currently overall our breakdown is 30 70 pretty much in paper. So 30% of our patient population prefers to complete a paper PROM versus an electronic PROM. But once people do take on the sort of responsibility, or are willing to complete the PROM, they do so very well. So the completion rates once people take on the PROM completion are excellent. But we're still learning a lot. There's still a lot of ground to cover in terms of really full integration, like I presented at the end of the presentation.
Okay, yes, thank you very much. To continue on this, probably we in Amsterdam are already also for, I think, 5 years busy in trying to try these questionnaires in people. We do it once a year, so we see patients most of the time twice a year, and we see them. We try to get these questionnaires once a year. but the response rate doesn't go up to 60%. That was the first year. And after that, people got a little bit of tired and they said, well, I already answered that last year, so why should I do this again? So how do you motivate your patients to say it's for them important? And what are we going to do with those people who do not respond to that questionnaire? Do you have an idea about this, or how did you solve that in France?
So this is one of the things we're currently working on, and I have to say that COVID has pushed this back a little bit. We just had meetings, no later than last week to discuss, how do we actually adapt what we were initially planning on doing on site, and some of the improvements in terms of response rate that we were able to achieve after 6 months of starting the project. We were able to do that with more in-person contact. And so it became really difficult to say, okay, well, we learned that, that extra nudge, in-person nudge actually helps us with response rate. And if we see that we have very motivated clinicians, that also we see, that also helps with response rate. But now we're considering, thinking about, trying to get people to respond in the time of COVID. So using, strategies of, making them aware of how their data has been used, how to feedback information, how to work on different communication, supports like, business card format or, email format, something that's a little bit more dynamic. And at the same time, being extremely conscious, I'm at least very conscious of this digital divide issue that we might have in people living with HIV. And I think that's one of the biggest takeaways of this project, of this work, is really being able to see, who is able to do this easily, and how do we ensure that if we want to capture these important dimensions like quality of life, like substance use, that we're able to target the people that might need help the most. And then the last response is we've hired someone to help us make sure that we have a good response rate for our second round of the evaluation. So personnel.
Yeah, that's very important as well. Richard, you recognize the point I just made? People are not responding. People say, well, I already answered this a year ago. Why do you want to know it again? And they do not always realize it's for their best, although that's what we think. It's for their best interest to answer all these questions.
I mean, two things I would say to that. One is about participation in development, and secondly is about data usage. So in the UK, I think what's worked well is that community were absolutely at the heart of the beginnings of positive outcomes. So when we wrote the first grant application, it was with community. When we got the grant, the first thing we did was do a number of community workshops. And it was interesting, picking up on Julio's point, some of our initial workshops were with the African Policy Network, and we had focus groups of people with African heritage living with HIV. We got community members on our steering group. Community members were part of the scientific panel all the way through. Community members have been promoting this, putting it into the standards of care. It was community that presented at our conference. So we've had really fantastic buy-in from the start. So that's really helpful. The other thing is, I think we risk talking, when we're talking about response rates and completion and questionnaires, we risk talking in our traditional language of epidemiological studies. And I had a meeting about this recently. I'm part of the HIV consensus, quality of life consensus group with Jeff Lazarus. And we have to be careful that we're not asking things to give us a complete epidemiological perspective of people living with HIV, what are their problems. That is not our goal here. People living with HIV are one of the most overstudied groups. What they don't need is a whole battery to describe them in great detail. Again, that's not helpful. Whose interest is that in? We need a measure which is very clearly about what matters to you right now. Let's discuss your answer. Where is the interaction about that? So most of the work that I've done in PROMs internationally, so in the Middle East, in Africa, and in the UK, has been about implementation. So sitting with the patient, I see right now, looking at this outcome scale, you're concerned about this and this. Let's talk about this a little bit more. I see in the open text, this is your major concern right now. Let's talk about this. It's a live document. We're not doing epi studies here. And I think we need to be very, very careful that that's how we approach things.
Yeah, I recognize it very much. But actually, what you described is have a good conversation with your patients and try to catch every subject where it might be of interest. So you don't need a questionnaire for that, actually. But we want to well, although that's how I look at it, we want people to prepare the visit to their doctor, so they give their problems a little bit, some kind of a thought, and we help them by sending out the questionnaire. But still, we have groups of patients, and I think Julio described that you have so many groups of patients that you cannot personalize all the questionnaires, because then it's personal conversation actually. And we have people, they say, well, I'm not going to answer anything about sexuality on a questionnaire. You have to ask me. And if you don't, then I'm not going to tell you. And even if you ask me, I'm not going to tell you at all also. So, and I have patients, they say, well, I don't use an iPhone, or I don't use electronic use, and I don't want to fill in the questionnaire. Then you keep, and probably those are the ones having the most problems that you want to discuss. How are we going to solve the issues in people who do not respond in every effort we put in it, make it so personal as we want to, but they're still not responding because it's not the way they want to conversate with us.
Yeah. And that's one of the findings we had in our research, is asking people, how should this be implemented? And there is not a one-size-fits-all approach. You have to absolutely tailor it to people. If you insist that things should be completed in a particular way, exactly as you described, Kees, you're going to have large sections of the population who can't benefit from this, and therefore, that lack of equality will only get worse.
Yeah.
In terms of, if I could just react to one of the things that
Please,
Richard said, I completely hear what he's saying, and I think that this is something that maybe we have as a kind of path determinacy that I see in my own work that we did in Bordeaux, just based on the needs and the origin of the project, and how people were used to working, but also the work that was done in the United States, which I followed pretty closely and listened to a lot of Heidi Crane's talks on the adaptations that they made. What's interesting is what I hear is, I think that people assume that it's supposed to, we're able to fulfill two roles, that using the PROM for research and also using it for clinical care. And that's something that I've been as I've gotten involved in this field, more and more sort of critical of, and thinking you really need PROMs that are specific for patient care, like you're describing, and PROMs that are maybe for research that have a completely different purpose. And I'm almost, what I've noticed in the literature is that I think sometimes we're very quick to assume that something that has worked in research can just be thrown into clinical care. And hence my provocative kind of questions about, unidimensional versus multidimensional, because the challenges of multidimensional, instruments can sometimes be, they're impossible to interpret, and they don't mean anything to people who actually are supposed to use them. And that's why maybe sometimes it's easier to go back to some of these simpler tools and develop really systems around them. That the PROM is not the only answer, but it's about what is the infrastructure you develop around the PROM. And that I think has to be, really developed and co-developed with everyone involved.
Yeah, and I think we're very early, all of us, aren't we, in that? Even though there have been some really great successes, and you're right, in the US. I think probably internationally, we probably aren't looking for the system, are we? It's probably what works for health systems, what works for populations. What works for you in Bordeaux might not be right for Italy, might not be right for San Francisco. And I think that's great. It's finding ways that improve quality and person-centeredness that are right for you. And I think that's really important. I don't think any of us should be kind of criticizing anybody's approach, because I think, whatever works is the right thing, isn't it?
Yeah, but that makes it very difficult then per center or per country where you work, because my next question was going to be for both of you, because there are, well, I think there are getting less questionnaires where you can probably use. You very nicely, and Julia also explained there were a lot of questionnaires from the past. We shouldn't use them anymore. But is there a place to develop, well, one more or less international questionnaire so we can compare countries or cultures with one another, or you think it should really be culturalized?
Great question. Great question. Tell you what's interesting is the cultural learning. So after years of doing outcome measurement, particularly with people living with HIV, The measurement of spiritual well-being came across as very clearly important, and we developed a measurement of that and routinely implemented it in clinical practice. But that was developed in Africa. And then when we internationalized our outcomes program, it became very clear to people living with similar illnesses in the UK, they also felt that their spiritual well-being was ignored. So what we've learned in Africa is now part of our UK dashboard in people with advanced disease. So actually, there are things you can learn cross-culturally. There are other specific things. So, for example, working with refugees in Jordan, we've discovered that social support is crucial, because if you want to discharge somebody home and care for them in the community, this is in the context of cancer, you presume a social network and home caring, but actually people's social networks are fractured. So there are some culturally specific things, but I think there are many, things like pain matters to everybody.
Yeah, that I understand. But about the cultural thing, I work in a hospital where we have all the cultures in our hospital, and if I have to think about which questionnaire I'm going to send to this person and which questionnaire I'm going to that person, that's going to be a nightmare in a practical way.
I'm sure that's the same for you, Diana, as well.
I mean, that's one of the things I was going to say is I think one of the challenges that we have in Europe is we have a heterogeneous population that we're caring for. And so getting, responding to sort of everyone's needs with a single instrument, I think is going to be really difficult.
Yeah.
So, some dimensions are going to perform maybe poorly in some populations, but they're going to be extremely indispensable for others. So we can't take them out, and I think that probably if we started to look at some of that data in a stratified way, that would become increasingly clear. Some of the sort of HIV specific questions in the instrument that we reevaluated in our population, they didn't appear relevant when we looked at the whole sample, but once we stratified across gender, all of a sudden they looked very different. That's just one example, but we only had 25% of our sample was women. So, all of a sudden, all of the items that I had discounted when it wasn't stratified on gender, I suddenly thought about them completely different once I looked at the stratified data. So that's just and I'm sure the same is true when you look at age as well. We have a population in Bordeaux where, a lot of them are have been HIV positive for 25, 30 years, but they're still, the cohort have been infected for 5 years who have never experienced severe infection, right? And the PROMs that we'll include for that population might be quite different. So that's that. I don't know how do we address those issues and get away from this huge battery that we were just talking about. Which I agree, we have to be thinking about feasibility and interpretability if we hope to achieve, the goals that these instruments are supposed to help us achieve.
Yeah, I mean, you think there have to be some core items that we all find relevant, and even if you've got a set of core items which matter to everybody, and then you kind of almost like an item bank approach that for other people there might be other items that are drawn in, but it must be, because I think we all get quite hesitant because we're all so aware of cultural difference and the fact that context is everything, that sometimes it stops us finding what might be core and common.
Yeah.
That makes me think of the computer adaptive testing approaches that they've really adopted in the US, where I think that maybe that helps you, reduce the number of items that you're imposing on people and still manage to achieve something that's similar.
I think that's a very important remark. That computer adaptive testing, that's how you call it. So if you don't have an issue with something, then you can skip the rest of the question and you go over to the other one. But that's only if you do it electronically.
Right.
Exactly. And you just described you have paper questionnaires, and well.
So this is what we're dealing with, and I mean, I'm thinking a lot about the infrastructure. One of the things that I've been extremely conscious of moving forward with this project and going from the ideal that I initially imagined, and thinking about what's happening in France in terms of just e-health policy. I mean, currently the presentation that was in the earlier session on the patient portal was fascinating to me. Because one of the ways in which patient-reported outcomes have been developed and used in Anglo-Saxon settings, as we say in France, has been for these patient portals. But in France, we are so behind on the patient portal. This is a completely novel concept, and we're just now starting to develop and have national efforts to develop patient-owned data. So,
Yeah.
you know, because that's in its infancy in France, it's almost premature for us to assume that we could use that as a way, as a, you know, a platform for integrating the patient-reported data. So this is what, these are some of the hurdles we're trying to overcome here, just in terms of just the speed at which the overall health system is advancing insofar as e-health is concerned.
Yeah. It's fantastic to see you developing that work, Diana. It's really exciting. Well done.
Yeah, and I think we have to finish this question. We can talk about this for a long time. I think we have to realize that what we are thinking about, what's best for the future, will probably be better in the future when everyone is dealing with electronic healthcare systems, etc. Then it's much easier. But we have to use small steps, I think. I think this is the end of the session, of the end of this question and answer. Thank you very much, Richard and Diana, for your answers and your discussion.